a disease that helps, that actually promotes the use of drugs as the solution. But the language that is used in type 2 diabetes is that your pancreas is burned out and now you aren't making enough insulin. The first part of that is absolutely false. There's no evidence at all that the pancreas has passed a point of no return. None. Indeed, there is, in fact, evidence to suggest to whatever degree a type 2 diabetic may have lost some insulin-producing beta cells, and that is not at all a universal phenomenon within type 2 diabetes, not at all. But to whatever degree someone might have, in fact, have developed a lower number of beta cells, there is a phenomenon, they can reverse it. There's this beta cell reversal, that this is not like type 1 diabetes, which is the person's immune system is constantly destroying the beta cells. Far, far, far from it. These are beta cells that have just, well, again, if it has happened at all in a type 2 diabetic, they've just stopped. And they can come back to life as needed. And there is, in fact, these recorded instances of beta cell reversal. However, that's the first part of the story that is commonly used with regards to type 2 diabetes, that your pancreas is burned out. And then the second part is that you don't have enough insulin. There is an ounce of truth to that, you don't have enough insulin, but that's a relative term, because what you cannot say about type 2 diabetes is that you don't have any insulin. It never goes to zero like it would in a type 1 diabetic. In reality, the timeline would look something like this. They started with this very low, modest level of insulin, like a healthy insulin-sensitive person has. It starts to climb over the years. And then, in fact, let me express it a different way. So here is insulin and here is glucose. And the insulin, because of their diet, they're getting more and more insulin resistant. But so even though their insulin is now multiples higher than it was before, but the insulin, it's not working as well, but it's working well enough that it can keep glucose normal. And this is why so often when we look at type 2 diabetes as a glucose disease, we don't diagnose it until a decade or so later than we could have, because it's only once the body becomes so resistant to its own insulin, and maybe in some people, the insulin starts to come down a bit, but never goes back to as low as it was. Never. It might come down a bit though, but it's still multiples higher than it was before. Now the glucose starts to climb, and then we detect the problem. So our glucose-centric paradigm of type 2 diabetes leads us to detect the problem too late, but it also leads us to treat it very, very poorly, because in this same paradigm of now elevated insulin and elevated glucose that we call type 2 diabetes, which it is a state of elevated insulin and glucose and glucagon, but that's another matter. The clinician will say, the clinician will have no regard for the insulin. Yep. They will just be looking at the glucose, and in a moment of true scientific and biomedical tragedy, they will say, let's just push your insulin up even higher by giving you insulin secretagogue medications like sulfonylureas, or outright give you insulin, exogenous insulin, and then we'll push the insulin to super physiological levels higher than it ever was before. And that is enough to overcome the insulin resistance, at least for a time. And we've reached our clinical goal, which is to lower your glucose. But the tragedy in that paradigm is that when we give a type 2 diabetic an insulin therapy, they get fatter and sicker than they were before. And the more we push up the insulin to keep the glucose in check, they become 3 times more likely to die from heart disease and twice as likely to die from cancer. And they'll typically gain about 20 pounds in the first 6 months of insulin therapy. So this is not, so we end up killing them, but we do so with great glycemic control. It's not a glucose disease. It's a disease of hyperinsulinemia. And so putting the insulin even higher is the worst thing we can do. And the analogy I use in the book is just so good, so I got to come back to it. It's, if I may say so myself, it's so good. It's like trying to treat a type 2 diabetic by giving them insulin therapy is like trying to help an alcoholic by giving them another glass of wine. You're giving them more of the very substance that caused the problem. A physician only knows what he or she has been taught. Now, and I don't mean that in a sort of, I genuinely don't mean that in a derogatory way, as if, well, they're too ignorant to learn something on their own. Not at all. Of course, far, far from it. These are very intelligent, very capable people.
Sure.
But if they haven't had this concept introduced to them one way or another, whether in a formal classroom setting or a podcast that sort of plants the seed, if you will. It's not fair to for those of us that sort of see things the way we do to expect them to see it the same way. Now, I think historically why insulin hasn't a focus on insulin hasn't worked its way into conventional curricula of undergraduate or graduate education in the realm of medicine. I attribute it to two causes generally. One is historic and one is scientific. Historically, the most obvious symptom of diabetes, type 1, type 2 even, but type 1 was of course historically much more relevant, insofar as type 2 was so uncommon. But the most obvious manifestation of the disease was itself a manifestation of the hyperglycemia, and that is the polyuria, the excess urine production. The person's urinating all the time, liters and liters of urine per day. And indeed, that is where the word diabetes comes from. We say diabetes because of the urine production. And that is itself a result of the hyperglycemia, because the glucose levels get so high, up into the 200s or so, and that or beyond. But once it gets to that point, we've passed a threshold where the kidneys can no longer keep all that glucose in the blood. And now the kidneys are draining this glucose into the urine, and that glucose is pulling a lot of water from the blood with it. And thus the person is urinating a lot. And that's where you'd see the flies coming to the urine or the dog licking the urine, which is why we added on that other term, mellitus, to refer to the fact that the glucose was enriched within the urine. So historically, I think we can see some rationale for the glucose-centric paradigm. And then scientifically, we also can, because historically, it was much easier to measure glucose. Even to this day, we've been able to measure glucose from human blood for decades longer than we have ever been able to measure insulin. And to the point nowadays where we can do it with a single little drop of blood in the convenience of our own home with a glucometer. You cannot do that with insulin. Insulin was only measured within the past few decades, and most assays to this day that measure insulin need radiation approval to do it, because they'll do what's called a radioimmunoassay. That's one of the most affordable ways of measuring insulin. And so the scientific hurdles are very real, which is, again, at its simplest, you could be in a doctor's office, do a finger prick, put a glucose strip onto it, boom, you got your glucose number, you're done. But if you want to get your insulin measured, you need a full blood draw. And you send that blood draw to the lab, and you've got to make sure that box is checked. You got to make sure that the patient's insurance will pay for the insulin, which many won't, or that the patient is alternatively prepared to pay that expense out of pocket, or the clinic is prepared to suck that cost.
Mm-hmm.
But one way or another, it doesn't negate the fact that there are some hurdles. So historically, scientifically, I think we can be compassionate when we wonder, boy, why do we continue to be obsessed with glucose, and why are we ignoring insulin? I think those are very genuine hurdles. But I would also now say that it's becoming less and less forgivable as we learn more, and as the ability to measure insulin has become so much simpler. I think we are past due to start making this transition and appreciate glucose. It certainly has a predictive diagnostic value. I'm not ignoring that fact. It on its own is a pathogenic molecule, but it pales in comparison to the pathogenicity of chronically elevated insulin. No comparison whatsoever. So we are past due. We need to start to make this shift back